Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, I speak with Dr. Bisola Ojikutu, the Health Commissioner of Boston, Massachusetts. We discuss her shift during the pandemic from supporting community coalitions directly to then leading the health department to find new ways to partner with communities within the city. Let's listen. Dr. Bisola Ojikutu, thank you so much for joining us on Public Health on Call. Now, you have been the Boston Health Commissioner for how long?
I was appointed in July of 2021. So that's sort of when I started working on things. But then I officially start in September. And then I joined Mayor Wu's cabinet in November after she was elected.
So you have been around for about 18 months across two different mayors.
Yes.
So we've talked to some public health commissioners on this podcast who took the job well before COVID, and then just got hit by a pandemic and just described the scramble that required. You took the job during COVID. Why did you do that?
Well, quite honestly, I had been working with some of our strongest, I call them our strongest community-based organizations during COVID, and really felt an intense sense that we needed to continue to mobilize the work and that we needed leadership in place that valued their work. And the job was offered, actually, it had been offered well before I actually decided to take it, but I really felt like it was the right time. I knew that it was sort of, a tidal wave of community events and community engagement that was happening at the time. And it really felt like a great opportunity to continue to lead that and to move that forward. And I felt really strongly about the opportunity at that moment.
So say a little bit more about this kind of work that you were doing before you became health commissioner that really inspired you to become health commissioner.
So I'm an infectious disease physician, and I have been doing work in partnership with communities. I was the chair of our community engaged research program through our Center for AIDS Research. So I did a lot of work in HIV. So as part of that, I essentially was working very closely with communities, not necessarily doing community outreach, which I think I define as being sort of unidirectional. It's like in one direction, and it's about giving information, really about developing partnerships and thinking through ways to actually invest in communities. So as COVID, sort of occurred, as it happened, what I noted was that community organizations started to coalesce. They started to come together as coalitions to say, hey, we need to do this work for ourselves because we don't necessarily trust the institutions that exist to do the work for us. And I was invited to join meetings, those sort of initial sort of building the foundation of this work, to provide them with, education and understanding of what was happening in terms of COVID-19. And then that ramped up as we started looking for partnerships in regards to the initial mRNA vaccine trials. And the work became really a part and parcel to what I was doing as an academic. Because I was, I'm an associate professor at Harvard Medical School. So it really just became something that I found to be really important. And I just saw how central it was to what was happening in terms of the pandemic.
If you could explain what you mean when you say that community groups got together and said, we know that we have to do this work ourselves. What do you mean by this work? What was it that you were involved in that was happening that was making a difference?
So I think that what happened with the community organizations is that they saw their communities being harder hit than other folks, increased rates of infection within various neighborhoods around Boston, which we knew had a higher proportion of people of color. And, certain groups, essential workers, as we all are aware, being at higher risk. And we started to see the mortality data coming out of the CDC and some of our local health department, death rates, and just seeing those disparities, clearly seeing that it mimicked what we have consistently been seeing in other both infectious diseases and chronic diseases in terms of disparities. And what I noted in those first conversations was discussion around mistrust and discussion about what it is that, people within our communities and within particularly the Black community felt would be done or would not be done to address this issue. And a lot of what was, decided to be done was really communicating to each other, having weekly meetings, bi-weekly meetings, getting boots on the ground, even when people weren't necessarily out congregating, but still being out, being visible, meeting with leadership and saying, hey, we know what's happening. What are you doing? Where is the money going? So those were the things that were happening that I really think is important for us to understand, that it was really this sense of not trusting the dominant institutions that led to a lot of these community coalitions saying, hey, we're going to do this ourselves. We're going to try to get funding, and we're going to make sure that our communities are prepared, they're aware, and that they know how to protect themselves.
Got it. And so you're working as a trusted partner with these community organizations, and the opportunity arises to become the health commissioner, to kind of cross through to the other side in a way. What were you able to do, and what was that like?
So I think it was challenging, but it was also very exciting, because what I was bringing to the table was this, experience working very directly as a sort of trusted person, trusted leader with these community groups. But then I was also coming into a health department where they had never had a Black person leading. This is not what leadership looked like at the health department. So I think that in of itself was a significant change that I was bringing to the health department. I think secondly, I felt as though, and people have told me this, so I feel like this is true, that I was bringing newfound energy, to the table, because I was coming from outside the health department in a period where attrition was high, morale was low, people were exhausted. I really felt excited about the potential and what was happening. And I think the other thing is that I brought a commitment to continuing to empower communities, to mobilize communities, to incorporate communities in what we're doing within the public sector, and making sure that they were benefiting directly from the funding and from everything else that's happening. And that's been an ongoing process, and it's a challenge, but it's certainly something that I'm committed to.
And it's not limited to COVID.
Yeah.
How do you think about using the community connections, the inspiration that you are giving both internally at the health department and beyond, to tackle other health issues differently?
Well, I think that one of the things that we've been looking at is our declaration of racism as a public health crisis. And for many jurisdictions around the country, many cities and counties, more than 200, have had these declarations. And in many respects, these have largely been symbolic. We were lucky in that we were actually given money, funding directly to address this issue. Now, I would say what the money's been used for thus far, because it was announced, declared in 2020, was really focusing in internally on institutional racism. So anti-racism policy, equitable procurement, things of that nature, DEI, diversity, equity, inclusion. The shift that we're making now is really looking at structural racism. So the policies, the systems that we all exist in, that we know have not benefited non-white individuals. And what is it that we could do as a health department in terms of restorative justice to address these issues with this pool of money? So we're working on this, and we've thought of different ways that would engage the community. whether it be through, housing resources or educational funds. We're really systematically thinking this through. And I think it's an important shift in the direction of where we will go with this particular declaration.
Got it. So you are essentially taking some of the lessons for what really made a difference to help inform people and engage people during COVID and saying, now let's tackle some of the other consequences of structural racism and structural racism itself.
Exactly. And I think it goes beyond this declaration and what it is that we're doing there. I think it's also about issues related to chronic disease and re-engaging people in care. And what is it that we can do as a health department to ensure, or at least assist our community health centers and our surrounding, health partners to do that work? Because certainly that's been a manifestation of COVID that we're still, dealing with.
So how does that conversation go? Let's say you're sitting down with a community coalition. They have been working for 2 years on COVID primarily, and that is a little bit of perhaps how they relate to the health department is all about COVID. And you want to get them to think about other types of issues. Is that a natural conversation to have with them? Is it a conversation where they're curious why you would be asking them about these things? What is that like?
It's a natural conversation. I think everybody knows that the disparities that we've seen over years, this has been a pervasive problem. And COVID presented almost an opportunity to elevate those issues. And now the question is, where's the funding going to come from so that they can still exist? Because many of them, we aren't sitting down at a table with, because they no longer really come together anymore. They no longer gather because they don't have the funding to do so. So that's really the question. What is the investment going to be long-term in these types of community organizations and coalitions so that they can do the same things that they did with COVID-19 for other, health conditions?
So people sometimes talk about the need for some infrastructure, basic, flexible funding for public health. And it sounds like if you had that funding, you might use that to support the ongoing work of community coalitions on a whole range of health issues.
So yes, I think partially, I would definitely say that that's the case, that I would attempt to support community-based organizations and to formalize the relationship so that it isn't just something that, is functional during periods of emergency per se. Really figuring out how it is that we either one option would be to establish a stronger community health worker program that's, well supported within our health department. Currently, we have what's called a Community Health Education Center, where we've actually trained more than 11,000 people in the fundamentals of being a community health worker. And it's reaching its 30th year milestone next year, which is great, right? But let's peel back the layers on that. The reality is that you can train lots of people to be community health workers, but if that's not a viable profession, if that's not a funded, that's not a real career path for folks, it's not something they're going to continue to do. So they'll have that certificate and that skill set, but now we have no place for them within our healthcare system. It's not a reimbursable service in most cases. It's not, well established, as I said, as a career. So, and oftentimes you have people who are taking on several jobs and then doing their, community health worker tasks sort of as a side gig or something of that nature. So it's unfortunate because we have trained lots of people, and lots of people do have this skill set. So certainly I would definitely spend money and effort, and we will be spending funding on that. But I think there are lots of other, things that health departments need to build infrastructure and build a more solid foundation going forward.
Well, it sounds like all the answers may not be in place yet, but you are really asking the absolutely critical questions, not only for what is necessary as, COVID and other respiratory diseases threaten the health of people in Boston, but as you look up and see so many other health challenges that need to be taken on right now. Dr. Bisola Ojikutu, thank you so much for sharing your work and this vision with us on Public Health on Call.
Thank you, Josh. I really appreciate the opportunity.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.